Excellent. So, good evening, everybody. Thank you for joining us today. We have our teaching session with Mr. Mohammed, who you already know. I'm hopefully aware that you know that he is one of our top consultants at St. Thomas's Hospital in the medical retina department. Obviously does a huge amount of work at St. Thomas's, but also does a lot of teaching externally too, and is a Royal College of Ophthalmologists examiner too. I won't go on. There's too much to say about what Mr. Mohammed does. I'll let him take over. If you do have any questions, then please do type it in the chat, or feel free to put yourself, take yourself off mute, and ask the questions directly. We do welcome interaction. And if you have any cases you want to discuss, then please do bring those to the floor as well. Other than that, over to you, Mr. Mohammed. Thank you very much.
Thank you again. So I know the title was dry AMD and RPE level disease. We're really just going to stick to dry AMD today. RPE level disease we're going to cover, that's really CSR and inherited retinal dystrophy. So I think we've got a couple of separate sessions for those. So I was just told, I'm just going to turn this radiator down next to me. It's too hot. I was just told that I went too fast last time. So if I am going too quickly, someone just shout, slow down, or tell me to go over it again. So feel free to interrupt. Okay, so should we get going? Bhavina, are we happy with that? Yeah.
Yes, absolutely.
Yeah.
Yes, please.
Okay.
Thank
Yeah.
you.
Okay. So I think most of you know dry AMD is incredibly common and it's a big problem. So if we look at site registrations, and this is severe site registrations, and that was the last sort of published survey from 2007, it's almost 2/3 or 60% or so almost is down to age-related macular degeneration. And so it is the sort of perfect ticking time bomb. BBC 20 years ago said the UK is facing a time bomb of sight loss from AMD. And if we look at the population demographic, the population is aging. So none of this is new. AMD, I think we all know, it gets commoner as the decades go by, doubles in prevalence with each decade. So when you look at people in their mid 80s, the prevalence of late AMD is really quite high, somewhere almost approaching 10%. So it is a challenge, particularly as the population is getting older. We're going to have more and more patients. So we don't really need to dwell on that too much. We thought we'd cracked this about 20 years ago when the first genetic studies came through. But of course, AMD is not a simple Mendelian disease. It's not like Stargardt's or Best's disease, where if your parents are carriers or if your parent has the disease, you're going to get the condition. It's a complex genetic condition. So we recognize 1, 2, 3, 4, 5 major risk genes, and there's probably about 30 minor risk genes. So it's a very complex interplay between what your heritability status is and what your lifetime exposure to food, nutrients, smoking, etc. has been. So, the plot just continues to thicken. And there's really very little predictive value in saying, well, you've got this genotype, so you're definitely going to get AMD. It is this complex interplay of environmental factors, diet, smoking, aging in general, and how your body is coping with aging, and those various genetic factors which then predispose you to the condition. And then, of course, every biochemical process, so phototransduction in this case, has metabolic byproducts. And if your ability to metabolize those metabolic byproducts is not great or is not robust, meaning you have these various major risk factors or your complement system is dysregulated, then it leads to accumulation of debris as a very sort of simplistic way of looking at AMD. So again, this series of talks is really about OCT interpretation. I think that was the idea when we first started it. So we're really going to concentrate on what the features are on OCT. Another really important paper which was published and not widely discussed was even amongst eye care professionals, and this was from the US. And it said primary eye care physicians, it was actually a good split of ophthalmologists and optometrists. In their review of almost 1,300 eyes, they were saying that actually intermediate or large drusen were still misdiagnosed and not recorded in 30%. So that is a problem, because the statistics from just even the ARED study said 20 years ago that if everyone who should be on AREDs is on AREDs, then you'd save 300,000 cases of vision loss over a 5-year period. So, it's these public health measures of minor interventions which have much more of an impact than the latest complement inhibitor drug administered every month ad infinitum, which will have very marginal benefit. So what we're really going to talk about today is how to diagnose AMD on an OCT. It's always important to think about, could this be something else? That question should always be there. And then we'll, as promised a couple of months ago, we'll touch a little bit on photobiomodulation and the geographic atrophy drugs. So we'll touch on those. So it's always good to go to basic definitions. So there is this thing called the Beckman Initiative, and there's multiple classification systems for AMD. Some are clinical, some are research orientated, some are on clinical investigations, some are on angiography, etc., etc. But this is a clinical classification based on what you observe of the fundus. So now, the difficulty with any classification system is the more simple you make it, the more fidelity you lose, so the less accurate it becomes. But it's really key in the fact that every patient you see is a very simple question. Is this patient over the age of 55 or not? We know that's a little bit arbitrary, but it's a good cutoff. So they recommended we use the term age-related macular degeneration, AMD, and it all revolves around visible drusen. So they say there's no signs of AMD if there's no visible drusen or no pigmentary abnormalities. If there's small drusen, and we have talked about this and we'll go over this again today, small drusen, less than 63 microns. So as we said previously, the vein as it crosses the disc is 125 microns. So if it's about half the size of the vein as it crosses the disc, that's a small druse. And medium drusen are 63 to 125, so still less than the vein as it crosses the disc, and no pigmentary abnormalities. And then large drusen are greater than 125 microns. And then neovascular AMD or late AMD is defined by macular neovascularization or geographic atrophy. Now, the importance is if you've got early stages, there's a very small risk of getting problems. But if you've got multiple risk factors, there's a huge risk. And that's when we have to identify patients to put in the interventions that we can. Why is my computer frozen? Okay, so again, there's sort of two key classification systems. I tend to prefer using the AREDS classification system because the AREDS has given us very good natural history data. So we'll come to that in a second. But these largely overlap. They're sort of confusing in a way because early AMD has got intermediate sized drusen, and intermediate AMD has got large drusen, and advanced has got geographic atrophy. So the terms are sort of, the definition and the term don't absolutely correlate. But the AREDS is good because stage one, it's got 4 stages as opposed to 5 on the Beckman clinical classification. And no MD is just very tiny drusen. You're allowed to say that's just a feature of aging because the retina ages just like every other bit of the body does. Early AMD is those intermediate sized drusen, et cetera, et cetera. So we'll go through some examples of this and how they look on an OCT. Now, the other thing is drusen subtypes, and the literature is incredibly confused because there's so many terms, some of which are used interchangeably, some are not. And I just rattled this off just thinking about it for 2 minutes. So hard drusen, soft drusen, small drusen, intermediate drusen, large, calcific, refractile, hydrophilic, hydrophobic, colloidal, cuticular. What do all these things mean? If you're really interested, there was a paper I was involved with which really looked at this in great detail. It's a very long read, about 30, 40 pages, but it does go through all the drusen subtypes in great detail. But some of these are overlapping. So some of these are clinical observed characteristics, whereas things like hydrophilic, hydrophobic are the behavior on an angiogram, basal-linear, basal-lamella, histological diagnoses. But there's, again, it's very confused in the literature. But we'll try and clarify that and have a sort of fairly simple approach. So the key thing is people can get drusen. You can get early onset drusen disorders. We are really trying to differentiate those from people who've got age-related. So that's where we go to the basic clinical classification. So the first question is this person over the age of 55? So if it's a 50-year-old with drusen, they really can't, by definition, have age-related macular degeneration. So they've got to have one of these other things to explain their problem. Now, if they're over the age of 55, and generally speaking, the patients we see are in their late 60s, 70s, and 80s, we just use the AREDS classification, small or hard drusen. That's the same thing. They're not different. Intermediate drusen or large or soft drusen. Large and soft is the same thing as well. But the key in trying to take up your sort of diagnostic abilities up a notch is really to try and identify who's at risk of vision problems. So that's the people who've got large drusen, subretinal drusenoid deposits, or reticular pseudodrusen as they were formerly called, focal areas of pigmentation, because that then tells us that the pigment epithelium is failing, and if the pigment epithelium is failing or dying, then we are in trouble because the whole visual cycle or the whole photochemistry of vision is then compromised. And then things like hyperreflective cores, and I'll just give little examples of those, and thick basal lamina deposits. All sounds very confusing, but it's much easier when we look at pictures. And then otherwise, it's got to be, by definition, an early onset drusen disorder. So it's either these anomalies, basal lamina drusen, large colloidal drusen, or one of the dystrophies. Most of the dystrophies don't look anything like drusen, but there is a little bit of overlap. So again, just so everyone's absolutely certain what a small druse looks like, they're tiny, tiny little excrescences. And if you've got, it has been defined, if you've got less than 5 in each eye, then that's just aging and not macular degeneration. So that's a small druse. And remember, drusen collect between the pigment epithelium and Bruch's membrane. So they're under the pigment epithelium. So over the elevation, you should still see the RPE, the interdigitation line, and the ellipsoid line, which has been just slightly deviated. The next stage is intermediate drusen. So intermediate drusen, by definition, are 62 to 125 microns. You can always get your caliper out. So most OCT machines, I think, have got a little caliper function where you can just get your cursor and just measure along the base, just so you find the biggest one. And if they're all smaller than 125 microns, they've still got intermediate, an early form of AMD. So that's what an intermediate sized druse looks like. And then we come on to the sort of more juicy aspect, large drusen, which is when we will then end up saying this patient's got AREDS stage 3 disease or intermediate AMD. And that's where you've got these variable size bumps, and you can often see Bruch's membrane. You don't see Bruch's membrane unless the pigment epithelium has been lifted off. So you can see that clean line there. The pigment epithelium is still clear overlying it. The ellipsoid's intact, the external limiting membrane is intact, but the interdigitation line, the photoreceptor outer segment tips, are compromised. We can't clearly see them. Now, we don't absolutely know because these scans are made upon optical principles and the reflectance of light, and anything which has been slightly distorted won't send back a clear signal. So we're not absolutely certain what the photoreceptor outer segment tip morphology is within that zone. So that's the basic classification of AREDS. It goes very much on just a small, intermediate, or large drusen in people over the age of 55. So if you see that, you can be fairly confident in making that diagnosis. The other high-risk characteristics for developing late AMD are then things like pigmentary. Hi, is someone asking a question there, or?
No, I think it's just
No.
interference. I'm just going to mute
Oh, right.
everyone.
Okay.
Thanks.
Okay. Yeah, so pigment irregularities. So we have a Heidelberg scanner at St. Thomas's. So on the infrared picture, pigment looks white. So all this white stuff you can see here is focal pigment migration. So why we call it pigment migration is the melanosomes are in the pigment epithelium, But as the pigment epithelium dies, those melanosomes are liberated and then migrate into Muller cells, in actual fact, which have a sort of macrophage type function. But it's more often at the tips of any chronic large drusen or retinal pigment epithelial detachment that you will typically see pigment accumulating, and often see linear streaks or a little sort of hot cross bun type appearance or a little stellate pigmentary irregularity. So that's always a sign that the eye and the photoreceptors and the pigment epithelium are struggling. And then the same sort of thing, and they're called different things, either hyperreflective foci, focal pigmentation, or pigmentary irregularity. It's all the same, it's just semantics, different terms for the same thing. And you just see these speckles are very, very bright. So pigment is white, the pigment epithelium is a bright white line. And as those melanosomes are taken up into Muller cells, we'll see those specks of pigment. So that's a really important feature, and we'll come on to an ARED simplified score classification, which just really looks at large drusen and pigmentary change. So again, I'm not sure if you're familiar with subretinal drusenoid deposits or reticular pseudodrusen, but they've really just come into our sort of depth of understanding over the last decade or so. And they're sort of even these are staged now. So staging is always good because it tells us that we have some understanding beyond just the recognition. So just recognizing AMD is one thing, but staging it tells us what that individual's risk is and just gives us a bit of a better understanding of the natural history of what's likely to happen. So if we look at an infrared reflectance image, you see this very dappled, widespread appearance. So all these little darkish dots. Now, the important thing to note is often the fovea is spared. They're often more predominant in the upper half of the retina, and they're more like dots in the middle, and they tend to be more little streak-like changes in the periphery. So a stage 1 drusenoid deposit is where the interdigitation line, so there's a bit of a rudimentary interdigitation there, so pigment epithelium, interdigitation, ellipsoid, and ELM. But here, the interdigitation, which is the photoreceptor outer segment tips, as they embed into the pigment epithelium, is very disorganized. So, of course, if you haven't got your photoreceptor outer segment discs, the whole visual cycle must be compromised by definition because form and function typically go together. And then so that then goes on to stage 2, where the external limiting membrane is intact. The ellipsoid should still be largely intact, but between the ellipsoid, which is very corrugated, and the pigment epithelium, which is still flat, you've got these collections of debris. And you can see why they're called pseudodrusen. True drusen are under the pigment epithelium, whereas these are very clearly sandwiched between the ellipsoid, the mitochondria, or the pigment epithelium. So again, there's a physical block. Now, these patients have got visual dysfunction. The visual acuity is often typically good. And again, this is a real issue with macular degeneration, that people still maintain good vision. But if you ask about dim light, mesopic function, reading speed, adaptability from light to dark, and vice versa, all those things are very compromised. And then stage 3, reticular pseudodrusen, and again, this very dappled, widespread appearance. You have these spikes, which then puncture the ellipsoid. So you can see the ellipsoid line is continuous there, but it's very interrupted here, and it's interrupted by these spikes and these little protrusions, which then are going into the photoreceptor nuclei. So again, just on a very rudimentary understanding, the photoreceptors have got to be very compromised for that sort of change. We've mentioned drusenoid pigment epithelial detachment before. By definition, it's where the basal diameter is more than 350 microns. And it's an important thing because these things eventually reabsorb. And as that resorption happens, it often leads to a focus of geographic atrophy. It's a slow process. It takes years to develop. But the first thing you end up seeing is pigmentary irregularities. And we know that happens That's happening here because you can see these little transmission lines going through. So the pigment epithelium is obviously compromised in that line. And then if you look carefully, obviously the ellipsoid line is dysfunctional there too. The ellipsoid is a mitochondria. If the mitochondria are there, then you've got to have a metabolic imbalance. So we mentioned hyporeflective core drusen. Again, I'm not sure how closely you stare at these things, but that's a typical druse, which is sort of grayish in between. But these next to them are obviously have got a much darker center. So again, this is where when that original thing of semantics comes in, lots of terms have been used, but the actual physical process, what's happening is these drusen are becoming calcified. Calcification happens with late degeneration, and then eventually they get cleared. But the other things we can see in this case is little foci of pigment, which is another independent risk factor. And these things often coexist. So you'll see pigmentary irregularities, hyporeflective core. So you can see that one looks very different to that one. It's not just the size, but it's the lucency within. And then a thickened basal laminar deposit. Again, basal laminar and basal linear drusen are histological diagnoses, but these are the anatomical correlates. So we can just see there's a very shallow elevation. We can see Brooks membrane there as a single fine line, and then this shallow elevation. Now, when we had the talk last month about wet macular degeneration, there is this thing, the double layer sign, which often is indicative of early macular neovascularization. So in these cases, we often do an OCTA just to be absolutely certain it's not vascularized. But when we see that, again, it's just a homogeneous plaque of waste material which is accumulated between the pigment epithelium and Brooks membrane. And obviously, depending on what the consistency of that is, what the constituents are, that'll provide a metabolic block. So metabolites, nutrients, oxygen can't transport across that relatively impermeable barrier, and then that'll have a knock-on effect on visual function. Then ghost drusen, you'll see they sort of go hand in hand with geographic atrophy. It's probably a continuum of hyperreflective cores, but it's where it's a very sort of heterogeneous collection of bright spots, dark spots within. I think the ghost thing came from the fact that they look like little Pac-Man type ghosts. If anyone remembers that game from all those decades ago. And then eventually these will end up undergoing collapse, and we can see these transmission lines, which tell us the pigment epithelium is very compromised. So you often see these overlying a period of atrophy, but again, a high risk feature for vision loss. So that's sort of the core of drusen and drusen disorders. The other major aspect of dry macular degeneration is geographic atrophy. And again, it's an incredibly wide varying phenotype. And there's many ways of diagnosing geographic atrophy, but it's got to be multimodal imaging. You can guess, say, from an OCT, we're primarily doing OCT teaching, but often you need the color picture and the autofluorescence image primarily in preference. And then things like the infrared reflectance and fluorescein angiography give us a lot more detail. But the key is very much the OCT scan and the autofluorescence image. And again, the great big mismatch between GA is these patients often have extensive geographic atrophy and a tiny little island of preserved retinal tissue, but that eye will still be 6'6". Now, 6'6", identifying single optotypes is one thing, but reading is something completely different. It's a totally different process. Obviously, these patients can't read because you can't scan across a large blind spot. And it's a real problem with all the clinical trials because we don't really have any good way of measuring, and there's no agreement. So these are things that are tried, low luminance visual acuity. It's a bit more functional because AMD patients really struggle in dim light. Microperimetry, I think, has largely been debunked because it's just too crude. And one of the lampalizumab trials really came through negative just because of the fact that they relied on microperimetry. Things like contrast sensitivity are probably a bit more reliable, but there are multiple tests. And obviously, if there's multiple tests, none of them are that reliable in themselves. Again, it's such a wide-ranging beast. Apart from just the sort of direct examination, there's multiple autofluorescence phenotypes as well. So we know size is important. These small foci, obviously less of a risk division than these large coalesced things. Unifocal center involving tends to grow more slowly than the multifocal perifoveal changes. And that sort of goes in with location. But often you get multiple foci, which then concentrically enlarge and then coalesce into one another. And then so that you get this ring around the foveola. And the foveola is the last point where the GA tends to involve and invade. And then the autofluorescence pattern, we look very closely at what's happening on the ring around between black is dead tissue. And if you see small spots of hyperautofluorescence, we regard that as an indicator that the GA is going to spread. If it's completely black with no white border, it's probably quite stable. And the worst phenotype is this peculiarly named diffuse trickling phenotype, and that's the most aggressive and most rapidly progressive, and it's multiple lobular foci of gray rather than black, and they just seem to enlarge at a rate of knots and within a couple of years. And these coexist with subretinal drusenoid deposits. Within a couple of years, most people have got really quite severe visual compromise. Other things that are being looked at now with AI modeling is actually that it's still uncertain what goes first. Is it the photoreceptor degeneration first, which then leads to RPE loss, or is it the RPE which becomes dysfunctional first, leading to photoreceptor loss? And there are polarized camps with this, and it's not particularly well understood. So the more sort of research orientated, completely clinically unworkable definition is the CAM group, the consensus atrophy and macular degeneration group. So they defined AMD. I mean, it sort of makes sense. This is what we so they've redefined GA, geographic atrophy, apart from everyone still calls it GA, as C-RORA, meaning complete RPE and outer retinal atrophy. So you've lost the pigment epithelium, you've lost the photoreceptors, and inevitably the choriocapillaris starts thinning out as well. And most patients with AMD have a thin choroid. Incomplete is where it's a little bit more disjointed, so these transmission lines are more interrupted. Complete outer retinal atrophy is where the pigment epithelium is still largely intact, but the inner aspects, so the ellipsoid and the interdigitation disappears. And then incomplete outer retinal atrophy is most typically seen with subretinal drusenoid deposits again, where there's still a rudimentary persistence of the external limiting membrane, but you get an interruption of the ellipsoid line, but the pigment epithelium is still largely intact. So these two, the pigment epithelium is intact. These two, the pigment epithelium is broken. We'll go through a couple of examples of these. So this is what we'd normally say is proper established GA. But of course, in terms of therapeutics, the game is over when you've got to this point because the photoreceptors are dead, the pigment epithelium is missing. And of course, there's many ways of getting atrophy at the back of an eye. It's not just age-related macular degeneration. So you can have drusen collapse, you can have pigment epithelial tears, you can have serous drusen which collapse on themselves. You can get involution of pigment epithelial detachments. There's many ways of getting, and even things like chronic CRVOs will end up looking like this eventually. There's only certain ways the retina can degenerate. It either becomes atrophic or pigmented or gets neovascularization. That's pretty much it. It's just recognizing the various patterns. So it's the hypertransmission because light is then penetrating the pigment epithelium, which is absent. We see these transmission lines and obviously loss of the photoreceptors. If the outer nuclear layer, that dark band here, is discontinuous, if you haven't got the nuclei, then you really physically can't have the cells, which is why the vision is inevitably poor in this situation. So this is an example of the same C-RORA, which is parafoveal. These are the much more sort of rapidly progressing things. So I've already said that they just enlarge concentrically and then just merge into one another and eventually dive into the center. So the average timescale from the appearance of the first focus measuring 200 micrometers to profound central geographic atrophy is about 8 years on average. But of course, you've got the fast progressors who'll get there in 4 or 5 years, and then the slightly slower rates of change. So again, we can guess what's going on just by the appearance. Aurora is incomplete RP and outer retinal atrophy. So there's an interrupted pigment epithelium. So you can see how the pigment epithelium there becomes discontinuous and then continues. You still got some hypertransmission, but it's solitary lines going through rather than a single band. And then you've got loss of photoreceptors overlying that. So I won't dwell on the other two too much because they're sort of difficult to see, because when you scroll through a whole scan of 50, 60 images, obviously every single line scan is going to show something completely different. But the key in complete outer retinal atrophy is that the pigment epithelium is intact, but the external limiting membrane is very discontinuous. The interdigitation ellipsoid is all discontinuous. So you can see how the photoreceptors are gone. So we may end up treating these cases very differently to people who've got established geographic atrophy, because actually some of the retinal structure, there may be more scope for recovery in these cases. And then this eye aura thing, it's very confusing, is where you've got largely subretinal drusenoid deposits, this continuous external limiting membrane, which is still intact. The ellipsoid zone is very interrupted, most typically by these spikes coming through. And then by definition, you have to have these subretinal drusenoid deposits. So the importance of classifying and staging is then so we can tease out who's going to do badly. So if it's stage 1 AREDS, just less than 5 tiny, small drusen, the chance of 5-year loss is less than 1%. If it's early AMD, which is intermediate sized drusen up to 125 microns, it's a 5%, but then it suddenly rises 5-fold if you've got bilateral large drusen, and then almost 10-fold if you've already had vision loss established in one eye. And at 10 years, the rates are even sort of more depressing, really, that if one eye is involved, 3/4 of patients will end up having second eye involvement at 10 years. If one eye is involved, almost 50% for severe disease in both eyes eventually. So we did mention there was a simplified score. That's the sort of official AREDS classification. You measure the size of a drusen, but this is an equally effective the AREDS simplified scale, and it's asking you to classify on each eye is, are there large drusen or are there pigment changes? So if there's large drusen, you get 1 point. If there's pigment changes, you get another point. So that's 2 points in the right eye. If you've got the same in the left eye, that's another 2 points. And then so if you say that eye has got 4 points, we know just from the simplified score there's a 50% chance of getting late AMD by 5 years. So in a way that sort of works well. You're not having to measure, you're just looking. Just look to see, is there focal hyperpigmentation? Are there large drusen? And that's a very, very simple way of scoring and getting pretty much identical risk figures. And then, of course, the importance of this is from the AREDS natural history study, which is still the most robust trial we have. Patients who've got stage 3 or stage 4 need to be on a vitamin supplement. Now, more stuff has happened recently. Just this year, another publication, again, just with our increased understanding of reticular pseudodrusen or subretinal drusenoid deposits. Now, the latest incarnation of the AREDS classification has brought into play not just pigment abnormality and large or medium-sized drusen, but the presence of reticular pseudodrusen as well. So we already said just a couple of minutes ago that if you've just got large drusen and pigment, your risk at 5 years is 50% of getting late AMD or established vision loss. We know if you've got pseudodrusen presence or subretinal drusenoid deposits, that risk goes up to 72%. So it's an important characteristic to identify on the OCT scan. And then going back to something I mentioned earlier, we still don't know how to use genetics. So there's an online risk calculator. So a lot of people did 23andMe, which has now gone bankrupt, and they got their risk alleles back. So you can punch the. Oh, hi, is there a question?
Yeah. Still no. It's still just.
No, okay. A quick slurp of my tea. Okay, so you can do these online risk calculators, but there's no sort of conformity between them. So, there's various sort of fairly simplistic questions. Racial origin, obviously, Black patients very, very unlikely to get AMD. We do see it occasionally, but then we'll always look very carefully if there's something else going on. Height and weight and very basic sort of dietary nutritional advice and level of education and things which tends to go with nutrition as well. But there's no correlation between this on the Harvard website or this on the KC Portland Eye, which is a brilliant genetics institute in the States. And again, it's just a little too simplified because of this interplay between the environment and your genotype. So the treatment advice is early AMD, just dietary advice, healthy diet, green leafy vegetables, oily fish, stop smoking, sunglasses for what it's worth. We don't really believe sunglasses confer anything useful, but a yellow orange tint will probably just enhance contrast a little bit and theoretically cut out high energy light. But it's intermediate AMD, so anyone who's got large drusen, or anyone who's got late AMD. So even if one eye is affected, there is a protective role in giving the other eye. And again, the most recent paper, again, an AREDS publication from this year, said actually there is a true protective benefit against geographic atrophy in patients taking these, whereas this was unclear before, but they've done post hoc analyses on these. So going on, so we said it's either AMD, in which case your patient is over 65 and they've got risk factors, either poor health, poor cardiovascular health, smoking history, or positive family history, or it's some sort of early onset disorder. So that's a really binary decision, young, old, and does it fit the whole overall general phenotype? So there's not many early onset drusen disorders. It's either just basal laminar drusen or cuticular drusen, same term. So different terms for the same condition, or large colloidal drusen. And then there's the masquerade syndrome. So we'll sort of come on to those, look very quickly at these. So this is a very sort of classic example of basal laminar drusen. And the key thing is they do look very different to AMD, is this very sawtooth type effect. So they're small, they're very discrete. When you look directly at the back of the eye, they're so-called hard, meaning they've got a very distinct edge. But on the OCT, they've got this very, very characteristic appearance of this jaggedy sawtooth thing with a very clearly delineated pigment epithelium in the early stages. And these are young patients. So if it's a young patient who's got this appearance, they've got basal laminar drusen. Now, there are syndromes associated with basal laminar. We'll talk about that in a sec. Now, it's not unusual, and we get patients like this frequently, that basal laminar drusen can often get the secondary vitelliform type change, which obviously the natural assumption is, oh my goodness, this is wet macular degeneration, you need an urgent review. So, we'll do an OCTA. We're sort of fairly clued up to this, but we'll most probably do an angiogram. But the key thing is, with wet AMD, you often get intraretinal fluid, or occasionally a speck of hemorrhage. And this is, hello? Was that a question again, or?
No, no, I
No.
will interrupt you if there is a question.
Okay. Okay. So it is the material collects, eventually liquefies. So it looks like subretinal fluid, or is subretinal fluid, but there's no other features, and the vision's stable. So that's a sort of key thing. So we just hold our nerve. We watch these things come, and then they just eventually clear. Sometimes they leave atrophy in their wake, but often it sort of settles back to a normal sort of level. And then the other key early onset drusen disorder is this sort of peculiar thing called large colloidal drusen. So they're very big, circular, and if you look, they've got these little concentric rings, so a little white spot in the middle with a little dark thing. So they've been described in the literature as owl's eye type appearance. And they're very sort of domed, very clearly delineated, and often early onset. I think this patient was in their 40s. This one was only in his 20s. and in the other eye. And again, you can see on the infrared image and probably on direct examination, you can often see this concentric little circle. So they're the only two sort of true isolated pure drusen disorders in young patients if it's not a dystrophy. So
Mr. Mohammed, there was a question in the chat saying basal laminar drusen are different to basal laminar deposits? Question mark.
yeah, so basal laminar deposits is a electron microscopic histological um, examination. This is again why it's all so murky, because the terms are so similar and then are different. So basal laminar and basal linear deposits are on electron microscopy and they're histological post-mortem steady eyes. Whereas basal laminar drusen are these little discrete sawtooth things. There is an overlap, there is an anatomical correlate, but one's a clinical diagnosis, one's a sort of histological thing.
Okay.
Yeah.
Thank you.
Okay.
Thank you.
So, so it was always understood that age-related macular degeneration had some sort of heritable basis to it. Well, firstly, it ran in families. Mainly, it was in Northern European extraction. We rarely see it in African or Black patients, not in the same sort of way. And then there were a couple of conditions, particularly Doyne's honeycomb dystrophy or dominant drusen or Malacia levantinase. They're all the same terms for exactly the same genetic thing. And they had drusen, which looked exactly like age-related drusen, but were just a very early onset. Now, it's dominantly inherited, so there's always a family history, and these patients end up getting pronounced multiple drusen in their 20s and 30s. And there's often little linear streaks. You can see little lines radiating out. And almost always there's drusen at the disc as well. So drusen at the disc is Doyne's, is the thing we teach our fellows all the time. There's the 3Ds. Drusen at the disc is Doyne's macular dystrophy. And again, it's one of the conditions where Bruch's membrane ends up becoming very, very apparent. And these patients can end up getting fluid as well, just because there's a metabolic block. That debris deposit is fibrotic. It acts like an impermeable membrane, so little pockets of fluid collect. That doesn't necessarily mean it's neovascularization. It's almost impossible on fluorescein angiography to decide. So often, if we have any evidence that it's changing, we'll just empirically treat these patients on the assumption that something may be there. If they don't respond, they haven't got it. So again, this is a very sort of pronounced appearance, and you get these little radiating streaks. And as I said, drusen at the disc and nasal to the disc as well, which you don't typically get unless it's something like mid-peripheral drusen. This is a slightly different case. Again, just widespread mid-peripheral drusen. The mid-periphery is from the vascular arcades to the equator, but at the macula, there are drusen. Again, Bruch's membrane is thickened. You've got these things which superficially look like they're called cuticular or basal laminar drusen in the literature. But again, the difference being is that these patients tend to be quite symptomatic, whereas basal laminar patients aren't. These patients have night vision impairment and always a positive family history in Sorsby's macular dystrophy. This is a really destructive condition. So again, it was an early onset model and a genetic model for AMD because they get the same thing. They get drusen and they very rapidly get neovascularization, very aggressive neovascularization. One of the other terms is pseudo-inflammatory macular dystrophy. Pseudo-inflammatory because it tends to look like untreated, a big inflammatory scar at the back of the eye. So again, very, very destructive, but actually do very well with anti-VEGF. So it is sort of disease modifying in most patients, but how long do you keep on giving anti-VEGF in patients who are in their 30s and 40s? There really shouldn't be any diagnostic dilemma with Stargardt's, but we do get patients coming through because ultimately the flecks do look a little bit like drusen, apart from their linear and reticular. And the key difference is, on an OCT that you get atrophy and bumps, but these bumps are between the pigment epithelium, so it's lipofuscin, and that's between in the subretinal space, essentially. So the pigment epithelium is still intact, And the key is on autofluorescence, they light up, whereas age-related drusen on autofluorescence don't light up. So again, a very simple clinical test that we can do because all these dystrophies tend to show hyper autofluorescence. So fundus flavomaculatus, that may be slightly more challenging, but of course, the clinical definition is people over the age of 55, and most of these patients will present in their late teens, 20s, early 30s. We get the odd patients coming through in their 50s, but it spares the fovea, so you don't get involvement in the middle. And the autofluorescence picture with Stargardt's and fundus flavomaculatus, you always get the sparing around the disc. So the phenotype is very, very different. So that really shouldn't provide any diagnostic picture. Sometimes these pattern dystrophies do. PRPH2 is the gene which is implicated. So we do molecular testing on any of our genetic patients now. The NHS allows that through our clinic. And again, if you look carefully, you can still see the pigment epithelium is flat and intact, and that these deposits are in the subretinal space. And I've just said a minute ago, it's lipofuscin. So when you do an autofluorescence image, they absolutely pop up and lights very brightly. Mid, again, this is maternally inherited diabetes and deafness. According to the diabetic literature, this is supposed to account for something like 2 to 3% of all diabetes, but we certainly don't see that we don't see this phenotype in our patients, but it's a model for geographic atrophy. So these patients get, in middle age, get something which looks very much like classic geographic atrophy with foci of atrophy. But again, the giveaway here is that there's often a history of diabetes, which is maternally inherited, and deafness as well. So again, we won't dwell on these too much. I'll skip over North Carolina, which is incredibly rare, but you can get these little drusen type changes in the atrophic patches. But of course, on an OCT scan, they're not really drusen deposits at all. They're just little lacunae within the pigment epithelium, and the atrophy tends to be what's called a caldera, a defect, a cavitatory defect in the retina, and it doesn't look like atrophy at all because atrophy is confined to the pigment epithelium and photoreceptors.
Mr. Mohammed, just to let you know, it's 10 minutes.
Yeah, so we
Right.
started 5 minutes in. I've probably got about 10 minutes to go. So
Perfect. Thank you.
hopefully I won't go too far over. We'll have time for questions afterwards. CSR sometimes can look like it because not everyone is in their 30s or 40s with CSR. We do get the odd older patient, and if they've got multiple pachydrusen, it can look very much like AMD. But again, the difference, as we've already said, is the choroid is often thinned in AMD, but in CSR variants or the pachychoroid spectrum, we'll see anomalous choroidal vessels. So again, the OCT is incredibly helpful. And to look at the choroid, you put your machine into the EDI, the enhanced depth imaging mode, where you see the outer retinal and choroidal details in more detail. And again, those changes tend to autofluoresce, and you get much wider RPE changes in those cases. So that's moving away from the dystrophies. Sometimes there's just general medical syndromes like SLE, systemic lupus erythematosus, which is it can be quite a serious condition, but those patients inevitably come with that diagnosis. We rarely look at the back of the eye and say, oh, you've got SLE. But it is recognized that you get drusen in these conditions. So it's just taking a good medical history. And just going back to that original point when we were talking about patients that come through with these basal laminar drusen, anyone that comes in our clinic with basal laminar drusen, we automatically, by default, check their blood pressure and dipstick their urine because there is this relatively infrequent but incredibly serious association with something called type 2 membranoproliferative glomerulonephritis. And that neatly brings us back because the gene mutation which causes this dense deposit disease, which affects kidneys, gives early onset renal failure and hypertension. The gene change is exactly the same gene that causes age-related macular degeneration. So there's that common root. It's a gene called complement factor H. So CFH was the first gene identified for AMD, and it's also the gene implicated in MPGN. So again, there's this common metabolic and common genetic roots, and there's often peripheral drusen in these cases. We see the occasional, it's worth mentioning because we have a lot of patients with sickle in Southeast London. So a lot of those who are on exchange transfusion programs who have got iron overload tend to get put on desferrioxamine. So we've seen the odd patient who comes through with these sort of pattern dystrophy type changes, which is a result of drug toxicities. There's always something to bear in mind. And you get these sort of vitelliform type lesions as well with the same drug toxicity. This is another drug which can give something which looks very much like AMD in the early stages and then rapidly goes on to um, geographic atrophy type appearance, pentosan. So it's been used in the States for about 20 years, and they have lots of pentosan maculopathy there. It's only recently been introduced to the UK about 3 years ago. So apparently you have to use it for about 5 years. So we're going to expect to see some patients with this drug. This is only used for people who've got a particular form of chronic cystitis, but there's lots of cases in the US. So this is coming to the juicy bit, which you might like or might not like, which is photobiomodulation. So it's been FDA approved and CE marked. Now, CE marked is a device mark. It's not a clinical trial approval. And the FDA has been uniformly criticized for being unbelievably lax, very, very secretive, and driven by financial pressures. So we in Europe often disagree with FDA approvals. Now, legally, we're obliged to understand the clinical trials. If you're offering this treatment, you have to know what the clinical trial says. You counsel patients on the risks and benefits with an informed consent, because there are risks with this treatment and the benefits are completely unproven. And it's this near infrared light. It was animal models. Remember, an animal's retina is very, very different to a human retina. It was tested in mice. A mouse retina is not a good correlate for the central macula in a human. And for whatever reason, it was said it stimulates mitochondria in some way. There's been numerous photobiomodulation trials over the last 3, 4 decades, in actual fact, none of which have shown any positive effect whatsoever. But look, we'll dissect the light site trial, which is what the FDA approval was on. They only used 100 eyes. Now, compare that to the ARID study, which was 5,000 eyes, or any anti-VEGF injection agent, which always has at least 500 eyes per arm over a 2-year period. And this is a 13-month with a 2-year report. So out of the 100 patients, 148 eyes were treated. That in itself, treating both eyes can be a source of bias as well, but only 98 were in the treatment arm. There were ridiculously high discontinuation rates. So they haven't explained in the paper whether it's a last observation carried forward or how they accounted for the patients that dropped out. And the impact of that is completely unclear because it wasn't reported in the paper. The treatment groups were also imbalanced. The sham group was 3 years older, so almost by definition, they'll have 3 years more worth um, of aging. The method of delivery in the paper is poorly described. Do you dilate eyes? Are the eyes open or closed? How do you protect the fellow eye if you're only treating one eye? What monitoring is there while you're exposing eyes? What is the impact of blink? And one of my colleagues who has a physics degree says you can get the same 3 wavelengths of light by staring at the sun for 2 minutes. I'm not saying you stare at the sun for 2 minutes because I'll give you photic maculopathy. It's a high treatment burden. Everything in MR clinics is about reducing treatment burden, not increasing the treatment burden. That's just the methodology. The results are slightly dubious as well. And this is the big unexplained thing, that most eyes had intermediate AMD. Patients with intermediate AMD have 6/6 vision. So why in this group did 30% have worse than 6/12 vision? That's unexplained. They had patients with early AMD as well. There's going to be absolutely no demonstrable change in someone with early AMD. There was no foveal GA, and GA moves slowly, so you're not really going to tell anything. Now, the thing when this paper's been dissected is we know in AMD clinics that vision fluctuates by 5 letters either side in any AMD patient. If you talk to any AMD patients, and we talk to many on eye injection clinics, they'll say it's a good day today, it's a bad day today. I didn't sleep very well. My vision's poor today. So there's a lot of fluctuation, and +5, -5 letters in any study is very, very common. And 70% of these eyes were within 5 letters of 2032. everything suggests that these patients were just getting regression to the mean. So for whatever sampling error, and it's statistics of a small sample, those patients perform badly to start off with, and then just regress to the expected mean. And we've got evidence of that because treated groups gained 5 letters, sham group gained 3 letters. That suggests a placebo effect. Half the mean gain happened in the first month, and that's just so if most of your gain happens in 1 month after one treatment, and then after month 1 to month 13, there was hardly any change in vision. It all suggests that it's a statistical error. And then there was the fact that the placebo effect is observed is non-treated fellow eyes tend to get a loss of vision as well. So it is complicated. And then the LightSight 1 said the sham treatment, which was a very low light, they took the infrared out, but then used 1/100th of the light exposure. In the original LightSight, they said that it's an active control group. So again, it's very contradictory in the trials. The later results, the 2-year outcomes, showed a widening, which was taken to be meaningful, but there were a large number of dropouts, and they were completely unexplained. And the 3-year outcomes will no outcome will explain the lower than expected acuities at baseline and the regression to the mean effect. So we have no confidence that photobiomodulation does anything useful. Now, slightly more in terms of preserving vision. Now, there's this stuff about preventing geographic atrophy, but the statistics explain nothing about the confidence intervals. There was no detail about OCT, and we've spent some time today looking at what you need to identify on an OCT to be a predictor of geographic atrophy. So all those things like subretinal drusen, hyperreflective foci. So it was a very crude study, not looking at things in the detail we'd expect with a modern study. And the most unexpected thing is a 5.4% risk in photobiomodulation of getting choroidal neovascularization. Now, this could again just be the statistics of a small sample size, but it's all unexplained. So actually, the ophthalmic community just doesn't believe in it at all. We need a better trial, longer duration trial with much larger numbers and better constructed with more meaningful measures of visual function. So we don't recommend it. I don't recommend it to any of my patients. Have we got time for complement? No, we probably haven't got time for complement inhibition. We can cover this next time.
We it depends on the audience. So we've hit 8 o'clock. I'm always comfortable going over. I would love to know, but an audience, any preferences?
And it's recorded, so if you can't
Yeah, absolutely.
stick around.
We've got one yes, please, and everyone else is quiet.
Yes, please.
Oh yeah, there you go. 2
Two.
yes, please. And some thumbs up. So please do
Okay. Yeah,
continue.
it shouldn't take too long. Well, I need to put on. Yeah, this going again. So, oh, what have I done?
We just need
Right. Yeah, here we go.
that's it.
Have you
Perfect.
got that? Okay.
Yeah.
So you've heard my thoughts loud and clear on photobiomodulation. I think we just need more evidence, really. So there is a Eurolight study, which Euretina are doing in a slightly more robust manner. But yeah, Shobha Siva Prasad did a lights mask trial. It was the same principle, and they were looking at mitochondrial function in more detail. And it was negative. And I've got plenty of patients who've got proper, true mitochondrial cytopathies and mitochondrial eye disease who, well, if anyone's doing it, treat those and see whether it works or not. It won't. It just can't. It's not real. And then the rodent model is really bad because if you use hibernating, our whole understanding on OCT and the ellipsoid line and what mitochondria are was all based on hibernating rodents. Hibernating rodents have their mitochondria shut down, and then the whole population of mitochondria in rodents is not a good correlate for humans. So the whole basis of that trial is just flawed. So complement inhibitors are used widely, ridiculously widely in the States. because it was FDA approved. And I've always said the FDA is lax in its approval, and it's financially driven and secretive, and they don't publish their reasons for approval. So there's two drugs. Thankfully, the European Medicines Agency and the MHRA rejected these drugs because they're hugely interventional, hugely costly for very minimal gain. So there were two seminal studies, one for pegcetacoplan and one for avacincaptad. They're all sort of completely unpronounceable names. And they were reasonably good trials. They were robust and reasonably well structured. But again, it's the how you believe in how the results are presented. So ultimately, growth is slowed but not stopped. And they present this headline figure of we slow growth by 14% or we slow growth by 20% at 2 years or so. But 20% of not a lot is very little. It is the key. And if you project across in time, the sham arm which progresses and the treated arm which slows down, you actually just delay reaching the same point by 4 months. So it's an injection in the eye every month for 2 years, and you'll be 4 months better off. Does that make sense? Yeah. So it's very costly, it's very interventional, and the definition of success is absolutely no change because these drugs don't affect visual function. Now, patients don't come in saying my GA is getting bad. Patients come in and say I can't see very well, and it does nothing for visual symptoms. So pegcetacoplan, again, there were lots of discontinuations. So the headline figures was, depending on whether it was monthly or bi-monthly arm, 21% or 16% at 24 months of slower growth. But ultimately, there was no statistically significant difference in visual acuity, reading speed, functional reading independent index, whatever that is, microperimetry, the NEI VFQ, the visual function questionnaire. So no functional benefit at all. And most worryingly, 13% end up getting macular neovascularization versus 14% in sham. And there's a biological reason why that happens. Avacincaptad was the same thing. It's the same. You slow down the growth very minimally. It's a percentage, but a percentage of what is the question. And again, no significant differences in best corrected visual acuity or low luminance vision, high discontinuation rates because no one wants an injection in their eye every month. And then again, a doubling or more than doubling of the rate of macular neovascularization. Even more worrying, I went on the company's website for their shareholders, and there was something I found which was consistent with expectations, no clinically meaningful difference on key functional endpoints. So the company knows themselves are selling something which has no effect on vision, yet it was approved. So again, it's always important to remember lies, damn lies, and statistics, and this is what it's all about. So they present their data in something completely counterintuitive. So they present their data of growth in the square root transform of the area. And if any of you know what a square root transform of the area is, well, here it is. The maths of it is here, but you can reverse calculate it. It's been done. So the avacincaptad reported the difference was 0.336 millimeters of retina versus 0.392 millimeters. So that's the equivalent of 56 micrometers of radius. 56 micrometers is probably 1 or 2 RPE cells. Now, one RPE cell subserves about 200 photoreceptors, and there's 2.8 million RPE cells. You're not saving a lot of retinal structure for not a long time. So it is just insane that they're using this stuff in the US. The other crazy thing is it did nothing to visual acuity. So the company then said, okay, well, we'll use geographic atrophy as a surrogate marker for vision. But we already know vision is not saved, but autofluorescence and geographic atrophy possibly is. But all you're doing is you're saving sick tissue, and that sick tissue is secretory. It secretes VEGF, which is why you get an increased rate of neovascularization. So it's doing nothing really for the anatomy except on a microscopic level. It's doing something, but it's not doing anything meaningful for a very high cost. And it's not doing very much for the anatomy either, except you're saving more sick tissue than than stabilizing retina. And then there are risks. In the clinical trial, it wasn't noted, but when it was released into clinical practice, 4% of patients were getting inflammation. When that was released, this is what happened to the share price of the company. There's been endophthalmitis as macular neovascularization up to 20% in the phase 2 clinical trial. There's AION, 6.7% rate of death in the clinical trial, completely washed over in the in the analysis on the report. And thinking, well, this just makes no sense. And then the cost benefit, how the NHS assesses it, is you try and work out what your QALY is. So how much time of your life would you trade off for the benefits that you receive? So if you've got no functional benefits, we'd say we would trade off 0 of our life. So if you have a high cost divide by 0, that's an infinite cost to a QALY. Now the NHS has got a cap for £30,000. Infinity is, or indeterminate is higher than £30,000, which is why it's not been approved. So we can't afford it. It's supposed to be 5 times the number of patients that we do with anti-VEGF. We can't keep up with the anti-VEGF demand. It just makes no spin. And the companies in the clinical, if you go to the conferences, there are just Apellis stickers and posters everywhere. The marketing is everywhere. And the sort of lunchtime paid for symposia rather than the clinical studies where there's genuine questions being asked. They're saying things like if the vision is kept stable for a bit longer, the patient can keep seeing their grandchildren, and all these sort of very emotive statements, which, my patient will do anything to keep their sight. Just because you're felt to be doing something is not a reason to be doing something. So, the European Medicines Agency rejected it, thank goodness. That was the correct thing. So it doesn't make sense on cost benefits, doesn't make sense on risks and safety, doesn't make sense on anatomy. It does absolutely nothing for the prognosis, probably counterproductive in a way. So, the patient asked, will this do anything for my vision? The answer is no. And the answer is probably the same for photon biomodulation. We can't believe it really does anything because the clinical trial is completely unexplained and not robust enough, and you can't explain why the vision was so poor at entry. If anyone hasn't read Bad Pharma, it's a great book. It explains clinical trials. So the key message was drugs are tested, or drugs and devices are tested by the people who manufacture them, poorly designed trials on small numbers of, which is exactly what I'm saying, unrepresentative patients, because real world outcomes never match clinical trials, and analyzed by flawed techniques which exaggerate their benefits. And the marketing spend of these companies is always twice on what their research and development is, and the negative trials are always buried. So take it all with a real pinch of salt. So what we talked about today, with my, how many minutes have I gone over? 11 minutes over, -5 to start off with, is we're talking about identifying dry AMD. So I hope you're a bit happy with that. The key is the classification. So the international classification says you've got to be over the age of 55, you've got to have drusen and pigmentary irregularity. And if you haven't got that, then it's got to be perhaps something else, an early onset drusen disorder. The early onset drusen is either basolaminar drusen or cuticular drusen or hard drusen, whatever you want to call it, or it's a dystrophy or syndrome. So you always consider an alternative. Now, even those young onset patients will end up growing old. So it's still always worth asking that question, does this still look like typical AMD? And in terms of the key current controversy is photobiomodulation and GA drugs. And that's really urge you, be really careful, because I think this will end up potentially being a legal minefield if people are selling this stuff and people end up getting choroidal neovascularization or bad outcomes, or in 2 years' time, it's completely shown to be debunked. It's thin ice you're skating on. So I think they remain completely unproven, and that's the criticism in the literature. So I'll stop there.
Thank you so much. That was really, really a whistle-stop tour, but really informative. Do we have any questions from the group? There's nothing in the chat at this stage. Oh, one message. Just a thank you, really. You've had some thanks. Um, what I'm going to do is draw this evening to a close. Thank you very much for everyone who decided to stay on a little bit longer. I'm just going to stop recording.
We do need not just feedback, but we want to discuss real cases as well. So we want to try
Yeah.
and I will try and talk less. I keep saying that.